Ashok, we cannot hear you. Are you live?
Yeah, good morning, everybody. We are live now. We can go ahead. Dr. Naresh, sir.
Yeah, shall I start first, sir?
Yes.
Good morning, everyone. It's a great privilege and honor to start the first Ioa-Spine subcommittee webinar series, the first in the series of webinars. So it's the vision of our Honorable President, Dr. B. Shivashankar, to have this Atmanirbhar orthopedics as a theme for this year. And he has initiated this excellent program of subcommittees and then running the series of webinars. This is a great opportunity to utilize the difficult times of COVID to get exposed to newer knowledge on this. So we have a series of lectures today, and we thought of involving exclusively the technical parts in this series of webinars. The short note, I'll request our Honorable President, Dr. B. Shivashankar, to welcome and give a welcome address. Sir.
Thank you very much, Dr. Naresh Babu. Good morning, everybody, and welcome all for this first webinar of the Spine Subcommittee of Indian Orthopedic Association. I must congratulate Dr. Naresh Babu for having brought in all the stalwarts from the spine to speak about various aspects, and there is a very interesting topics which is going to be covered by all. I must also thank the ASI President and Secretary. I can see the ASI President, Dr. Shankar Acharya, on the screen right now, for having got involved with the IOA subcommittee and helping as mentor for this subcommittee. Thank you very much. I once again welcome all and hand over back the mic to Dr. Naresh Babu.
Thank you very much, sir, for those kind words. Now I request our Honorable Secretary, Dr. Naveen Thakkar, sir, also to welcome the faculty.
Yes. Good morning to all. Without wasting much time, to go for academic fest with the focusing on the general orthopedic surgeon, the topics are kept very selected and very fantastically with the good faculty. We are thankful to Ioa-Spine subcommittee and all the faculty. Please go ahead with the academic activity. We are waiting for academic fest.
Thank you very much, sir. So it's to introduce the faculty, we have the President of ASSI, Dr. Shankaracharya, and Secretary ASSI, Dr. Gautam Zaveri, and past President of ASSI, Dr. Ram Chadda, and we will be Arvind Kulkarni will be joining us very soon. So without wasting much time, I'll request the first speaker of the day, Dr. Ram Chadda, to speak on success mantra in spine surgery. Sir, over to you, sir.
Morning, friends. We as spine surgeons deal with a difficult situation. We make unhappy patients less unhappy. And I feel that we have to learn, and that's the only way that we would be able to progress and move through life, not just go, but grow through life. We are a foolish breed. We attempt to tackle essentially anterior lesions from behind and vice versa. We cause significant disrespect to soft tissues, highest disregard for the stabilizing structures of the spine, and at times, we end up doing more harm than good. This is because we deal with mechanics, biology, and neurology. We deal with an interesting subset of patients who come to us, and I divide them into three: the acquisitive, contributive, and receptive. There are some patients, whatever we do, they'll always be unhappy. Then there are the contributive, who are happy, but they are wanting more. And finally, we have the receptive patient who propagates your name and fame. I strongly recommend that decision making and choice of patients is the most critical success mantra in making unhappy patients less unhappy with spinal ailments. We should try and get as many receptive patients and as few acquisitive patients as we can. I have evolved and learned from my mistakes. And before I unlock and decide to operate and use my instruments, I plan to share a presentation which represents the foolishness and the hunger of spine surgeons. Albert Einstein, regarded as a genius, reviewed and corrected his theory of relativity 7 times, which means that failure is a stepping stone to success. And I look at 4 basic objectives: the purpose of my surgery, the planning of my surgery, the process of my surgery, and precision during my surgery. Let's begin with the purpose. Whenever we have decided to take a patient for surgery, ask yourself the question, is surgery the only option for this particular patient? Can I make him less unhappy? Is the risk-benefit ratio in his favor? If all these are yes, then and only then, does he need decompression? Does he need a fusion? Does he need some deformity correction? Or does he now need the new kid on the block, a replacement? Having pinpointed which of these 4 he really needs, and it may be more than one, please pause a moment and realize and rule out if he is an outlier, which means he may be an exception to the rule. Always remember that the rationale of a surgical decision is not decided by the ringmaster. Happiest are those patients who buy the operation rather than those to whom you've sold it. Let them really go through that entire non-surgical gamut before they agree for surgery. Now coming to the second mantra, the planning. Always rule out a latent vitamin D3 or B12 deficiency, which is prevalent in our country and adds to the bone pains and the nerve-related symptoms. Never miss out a seronegative spondyloarthropathy, which may affect the sacroiliac joints and may mimic a low back issue. Please remember, osteoporosis is a silent killer, and it hits the surgery much more than you actually can predict. Correct it wherever possible. Gout is also a masquerader. Besides diabetes mellitus and those malingerers coming for workman compensation, wanting certificates not to attend work. And it's become more so now in this work from home policy. Always rule out all medical comorbidities, especially things like neurological Parkinsonism syndrome and all these things which affect quality of life and final result of surgery. Always read the fine print. Have a detailed history and clinical evaluation, and that's the only thing that can differentiate a spinal from a non-spinal pathology and an orthopedic from a non-orthopedic one. All patients with back and neck pain have a functional overlay to a lesser or a greater extent. Stress, fear, and anxiety can multiply the problem, and we are obliged to correct that before we offer them any surgical intervention. Finally, coming to the process, the third mantra, take a proper informed consent. Tell them everything that could go wrong, and don't do it just half an hour before the operation. Do it in your last counseling in the clinic, a day or 2 prior to your surgery. Let them go home, think about it. Have your entire team give you an opinion. What is a team? A team is people who together achieve more. Fine. However, a team is a set of people who trust each other, who take care of each other's backs. Look for all the operating room readiness. Is your image in place? Are your implants there? Is instrumentation in order? If you need neuromonitoring, is it available? Navigation, robot, post-op ICU, bracing, rehabilitation. And finally, have you preempted the patient for lifestyle modifications and dietary changes in the future? Having done that, you have to decipher the Da Vinci Code of radiology. In the lower back, please remember, there is transition vertebrae, lumbarization, sacralization, L5, L6. Does it really matter? Well, it does. Always insist on a pre-operative X-ray. It's only an X-ray that mimics the intraoperative C-arm. Embarking on a surgery without a plain X-ray can be disastrous. The pre-op X-ray matches the intra-op C-arm, and you have to count the mobile segments from below and plan the surgery in that Google map which is in there. Something which I have learned over the years and I practice every time. Have a surgical partner who has an opposing personality. Someone who can look at situations differently, who can smile when you are stressed, and someone who has a low PDI. This is airline terminology, power distance index, pilot and co-pilot. They should be friends, they should be colleagues, they should not be someone above or below, but at level, so that they can indulge rather than restrain. Your partner across should have interactive indulgence during the surgery rather than a reactive restraint. It's only an indulgent man across the patient who can actually prevent a complication before it occurs. So indulge rather than restrain, and have a buddy who helps you. Coming to the final part, the precision. Positioning, preparation of skin, level marking, C-arm draping and positioning, headlight, loop, microscope, drill, minimum instruments on the tray, favorite instruments of the surgeon to be kept handy. Avoid fiddle factor. Let the nurse be the one who's been with you more than once, and have all your bailout in the OR, whether it is T-seal, Durapatch, Flow Seal, whatever you may need. Please remember, we may be foolish, but yet be quiet and notice everything. I pad the knees and ankles. I secure the Foley's catheter in the elderly patient. Keep the abdomen, chest, and eyes totally free of pressure. Pad all the bony prominences. Secure the patient firmly to the operating table. Having done that, I mark the level. I normally do it on the opposite side with a needle. Suppose I'm doing a left-sided L4-5, my needle will be on the right side of the L4-5. This gives me an idea where I am and keeps me away from the surgical area. Having said that, you may choose to use infiltration. I don't anymore, but earlier I used to, which was saline adrenaline, and have adequate draping. Finally, take the leap. Please remember, conventional disc surgery could be either a fenestration discectomy, a laminotomy, an interlaminar discectomy, or a laminectomy. Whatever it is, expose the hemilamina. And I shall give the example of just a microlumbar decompression. Expose it, use a 1-inch dry roller pack and a good Carb Elevator. Use this versatile microlumbar retractor, originally given to us by McCullough, Indian versions which are Atmanirbhar available here. Approach the ligamentum flavum, check the C-arm before you do anything. Check and verify with your pre-op X-ray and your intra-op C-arm that you are on the right level. Having done that, go for the edge of the ligamentum flavum. The ligamentum flavum goes and attaches below the overhanging lamina. You may choose to take off a little bit with the Garrison ronger, or go in with that small AO type of periosteal elevator and detach the ligamentum flavum. Having done that, you would identify the edge of the ligamentum flavum. Once you've identified the edge of the ligamentum flavum, and I have the cranial end to the left and the caudal to the right, the instruments are going from the caudal towards the cranial below the lamina, and I am on the left side of the patient. I go in, may have removed a little bit of the lamina, identified that edge of the lamina that I have taken out with my rongers, and identified the overhang of the ligamentum flavum. There is one area where it gets deficient. You may go central, as a lot of people do. I tend to go just above the edge, superior edge of the ligamentum flavum, detaching it from the undersurface of the lamina above. Having done that, you need something to hook and turn it around. You may use a ball tip retractor, or you may use a modification of the one number that I have now modified and use it very, very commonly, which is bent. I just flip it in and turn it by 180 degrees and lift off the lamina. Having done that, I could either cut it with a 15 number knife, or I could just detach it from the central side. It comes off fairly easily. Then with a small pointed forceps tissue holding, I lift it up and detach the ligamentum flavum. There are some people who love and keep the ligamentum flavum. The choice is yours. Having done that, we have to now go for the nerve root. We don't look for the disc, we look for the nerve root. The operation is nerve root decompression. So this is a double angled root retractor which needs to find the shoulder of the nerve root. So we have to go and expose the entire nerve root as far as possible and then gently retract the nerve root to identify the annulus. A few patients will have an extruded fragment or a protruded fragment which pops out. There are others who may need a formal annulotomy. A foraminotomy I do prior to getting my disc out. I identify that whole root because my operation is nerve root decompression. Having said that, there are times where you are foraminal or close to the foramen in a narrow canal where you may have to do a spine annulotomy and detach the annulus and pick out the nucleus from within. Restrict the annulotomy to a single slit, maximum being 4 to 6 millimeters. More than 6 millimeters, annulotomy has a higher incidence of recurrence within the first few years. Then use these fine disc punches, the straight one and the curved one, to pick up the nuclear fragment. Having said that, then get your pen field in and look for any more fragments. Pick up that disc fragment, and that disc fragment should match that Google map in your brain. If you've imagined it to be 2 centimeters, it has to be somewhere between 1.8 to 2.2 centimeters when you take it out. Please remember, if it doesn't match with what you have in your mind, you got to look for more. Remove all the loose fragments and check the mobility of the root completely. Do only a bumpectomy and loose fragment removal. Today, we don't do a complete nucleotomy or a radical annulotomy. We've stopped doing curettage of the end plates. In fact, it causes increase in sepsis and long-term subsidence with significant back pain. So just do offending fragment removal with complete nerve root clearance. The operation is nerve root release and clearance. It's not a complete discectomy. Can there be bleeding? Yes. How do we achieve hemostasis? Be very proficient in using the bipolar. There are epidural veins which can be easily identified with your loops, with illumination, and with the microscope. Use suction and pick up all those roots. A little more bleeding, you can take care of gel foam pledgets and put them there till you get hemostasis. Some people choose to keep the gel foam, some people choose to take it out. Choice is yours. Literature says it could be kept in there. Finally, that's the scar. A summary of the procedure, you put in the retractor, go in, identify and do a small laminotomy, identify the herniated nucleus pulposus, remove the extruded or protruded fragment, decompress the nerve root completely. Einstein, the genius, said, insanity is doing the same thing over and over again and expecting different results. However, in microlumbar decompression, like many things in orthopedic surgery and spine surgery, the corollary may be true. We must understand that we have to have our foolishness and follow it. Our hunger should not stop short of excellence or perfection. Please understand, it's very unforgiving as a spine surgeon, but at times it's the most gratifying of procedures in orthopedics. Triumphs and turmoil will be a part of the game as a spine surgeon. And self-doubt will creep into every spine surgeon's life on a regular basis. How then does one keep one's head above the water? Please understand, don't let the noise of others' opinion drown your inner voice. Have the courage to follow your heart. It somehow knows what you truly are and want to become. Everything else is secondary. Opinions are not facts. Stop worrying about what people think about you. Stay hungry, stay foolish, remain a learner all your life. All of us do not have equal talent, but all of us have an equal opportunity to develop our talent. I request, the biggest success mantra is that the future belongs to the competent. Attend meetings, train yourself, get good, get better, and be the best. Thank you very much for a patient hearing.
Thank you very much, sir. That was a great lecture and words of wisdom. Can we have small discussion, Ashok? Can have the gallery mode. So, welcome Dr. Mukhopadhyay, sir. Welcome Dr. Gautam and Dr. Aravind also to the panel. Ramchandra, sir, Aravind. So if you want to say one success mantra to general orthopedic surgeons who are practicing across the country, so what will be your great suggestion as a senior most spine surgeon of the country?
Well, I would say that the most important is the decision making on which patient to operate. It is the most critical step as far as success of a spine surgery is concerned. So the indication remains primary and above all. Choose the right patient.
Excellent, sir. That was an excellent take back from the lecture. Thank you very much, sir. Stay back and we will be asking you for the discussions in the panel at the time.
Comment,
sir, of course. Shankaracharya, so I'm over to ask you in the capacity of president of ASSI, I request our current president, Dr. Shankaracharya, to say a few words and also participate in the discussion. Sir, please go ahead.
Okay, good morning, everybody. I thank Dr. Shiv Shankar and Dr. Thakkar for organizing this, and I'm glad the job has been given to Naresh to organize the IOA sub-seminars on spine surgery. And this is a very interesting start with Ram Chadha's talk. I wanted to just congratulate Ram, who is like my brother and very close to me, for his help he has always given me. I've been hearing him as a student from 1990 onwards, and I never get tired of hearing him because I always get motivated and inspired after hearing him. So he's like my petrol filler. He fills me up with enthusiasm, energy, motivation, and everything that he said today is very valid. I think you have to have a ritual and in practice, so you have to choose the right patient, make sure that the patient earns his surgery, and you should not sell the surgery. That his words are most important to keep in mind, that the patient, you should not sell the surgery to the patient. The patient actually should demand surgery from you, and then be very careful in your whole surgical steps. I think Arvind is going to tell you about a detailed checklist. And there is a little difference between spine surgeons and arthroplasty surgeons and joint replacement surgeons. I don't want to offend anyone, but I have always heard joint replacement surgeons talk about numbers in a day. Spine surgeons cannot talk about numbers. They talk about the results or how they did with the surgery. So every spine surgeon after his surgery goes back, or I tell my fellows after every spine surgery, go back, look at that screen, TV, view box, and ask yourself, have you done what you expected, or could you have done better? What mistake did I do, and where did I go wrong? So that you keep in your mind a pre-op plan, and then you go, which is always stuck in my theater on a piece of paper, and you go back to the same pre-op plan and look at the view box and say to yourself, have you done well enough, or where did you falter? And keep correcting yourself. So as Ram said, perfection, there is in spine surgery, you have to do the same ritual over and over again, and you'll be amazed how sometimes, in spite of doing hundreds of surgeries, you may be faltering in one step because you missed a step. With these words, I thank Naresh for having organized this, and thanks Dr. Shiv Shankar and Dr. Thakkar.
Thank you very much, sir. Thank you, Ramchandra, sir. These are the things which are nowhere written in the textbooks. Unless we listen from the experts and then who has passed through these phases, we never know this. The next coming topic is also a topic which is not written in the textbooks, and you can't find it anywhere in any journals. It's by observing your mentors or your teachers, you will get these techniques. This is on how to select an ideal instrument for spine surgery and how to handle your instruments. So over to Dr. Shankaracharya, sir. Sir, you can start sharing your screen. So you'll be telling us how to select a proper instrument for proper procedure and how to maneuver your instruments safely without injuring or without causing any complications. So while that slides are coming up, I welcome Secretary of ASSI, Dr. Gautam Zaveri, sir, onto the panel. So thank you very much, sir, for joining.
Thank you very much, Naresh, for inviting me here to be today. I'm grateful to IOA for giving me this opportunity.
Yes, sir. Your slides are visible, sir. You can start.
Okay. Basically, I am going to talk about basic spine instruments, a few of them, and I focused on the main instruments really. So the first point was this was an article one of my fellows actually sent me, that every athlete or every singer have their own instruments, and you will be surprised that very few group of surgeons have spine instruments of their own. So I think a lot of people in Bombay have their own instruments because they do operate at multiple hospitals. But people like us who work in one hospital or mainly one hospitals normally do not have a set of their own instruments. And it will always be worthwhile for surgeons who start into practice of having being comfortable with their own instruments. Obviously, if you have your tools which you are comfortable with, it's always easy and your stress level is less. So that's first point I wanted to spread. I do have a set of my own instruments, but they are not as elaborate as one would like to. And it was worthwhile over the years when you go to the conferences to accumulate the instruments which you think are most suited for you. So you have in spine surgery, obviously you will have general instruments, you will have some dilators and retractors to give you the access to spine, and they could be different types. So from open retractors to mini open retractors, as McCulloch retractors Ram showed, to tubular dilators, which I think Arvind will tell you about. Then you will need some dissectors, Carb elevators. I'm sure everybody has used Carb even in the elevators and curates. Carb elevators are an integral part of spine surgery. So you must have about 3 or 4 Carb elevators in your set of different sizes and different lengths, because one size and one length doesn't fit all situations. Then you need rongers, drills, Garrison punches, and pituitary forceps. A majority of orthopedic surgeons suffer from musculoskeletal disease and some cataracts and things like that, purely because of an occupational hazard. So you have to be very careful what is your position when you're operating. You have to be comfortable, because a lot of them, I see a lot of plastic surgeons coming with cervical spondylosis and kyphotic spine, which I've operated on. So I think you're because they tend to you're a lot of loop for hours together. So it is important to keep these in mind. So obviously, staying fit like Abhay is a mantra for orthopedic surgeons, and he is also a great motivator. Ortho versus spine surgery. Spine surgeries are close to vital nerves. So we have neurology, we have a spinal column mobility, and we have vertebral bodies and bones. So we have to use the surgical instruments of orthopedics, which have a significant amount of power or torque. But if we use that in spine with the same intensity as we use in general orthopedics, there will be a problem. So you will have to have finesse and dexterity as well as strength and agility. So most spinal and the surgeons have to have the feel and dexterity of both the things. So you may have to be very, very gentle as a neurosurgeon would be while handling an epidural tumor or an intradural tumor, as well as the ability to correct deformity with some amount of manipulation and agility with correction and help from your team. So we do use power tools and more these days, but you have to be very careful when you're using power tools. So fine motor skills of a spine surgeon are very important. So you must learn how to keep your hand in the table or in the position when you're standing. So fine hand-eye coordination with motor skills is something which you need to learn. And especially spine surgeons, we have a skills room where they learn how to do suturing under the microscope, how to do the repair, how to have the hand-eye coordination under the microscope, or if you are using a loop under the loop. So the precision is very important. So let's me come to first most commonly instrument that we use is the Garrison ronger. And without a Garrison ronger, you probably cannot do any spine surgery. And so it is a must in every spine set. And it has various lengths. It has various sizes. So it has length, sizes, and normal ones which we use, they come in 1 millimeter, 2 millimeter, 3 millimeter, 4 millimeter, and up to 5 millimeter sizes. They come into from smaller size, 80 millimeters to 180 millimeters in length. Then they come in different foot plates. They come in thin foot plates and thicker foot plates. The thinner foot plates we use normally in cervical surgery and in thoracic surgery, because you don't want to be indenting onto the cord much, and that's very important. And the thicker foot plates can be used where you want to take off a bigger chunk of hard bone. And they have different angles from 90 degrees to reverse 90 degrees to 140 degrees oblique. So they have different angles. Then they have self-ejector systems in them, and they have power systems also. So this is a small microscopic discectomy, and you see how a Garrison ronger is used. So you should not be rotating it too much. So you should be just simple. So this is where Ram was showing the upper edge of lamina. So this is the midline. This is the lower lamina. So the ligamentum flavum is attached to the superior surface of the lamina below and under surface of the lamina above. So this is the facet. This is a Taylor's retractor, which I use very frequently, and people may have seen. So I hinge the Taylor's retractor on the facet, and that's the only instrument. So this is like a tube system, so same incision, and then you go on the under surface of the ligamentum flavum, and as soon as you see the edge of the ligamentum flavum, that's all you need to do, and put in a dissector. As Ram showed, you can use a ball tip probe, right angle ball tip probe, or you can use the pen-filled dissector, which is curved to 90 degrees to elevate your ligamentum flavum. Or you can go on the midline. There is always a defect in the midline from which you can take off the ligamentum flavum, and then come to the dura, and you can see the dura. So you must come to the edge of the facet. So this is the edge of the facet. So this is the minimum amount of ligamentum flavum you have to remove, or if you want to keep, you have to keep a flat. So So there are various types, as I say. So they come in 1 millimeter, 2 millimeter, 3 millimeter, 4 millimeter, and they have these are the bite widths. So they are 40 degrees, 90 degrees, and this bite length is also there. So you can have a longer length to smaller length. The most commonest we use are the 9 millimeters, the 10 millimeters, and sometimes for the thoracic I use the 15 millimeters because you need that depth to go in. So you need to have all these with you. Then you have nowadays powered Garrison rongers. I have used a couple of times. We initially purchased one, but then I didn't find it that helpful because it doesn't give me that precision. And it has, but it can be used. It can be used in long cases, difficult cases, and this is quite a good advancement. So people can try this, but and it reduces fatigue, especially if you're doing multiple levels. And so this is just like any pneumatic or powered instrument that you use in nailing, and so you could use manual preparation of the for nailing, or you can just use powered. I don't think anyone does manual now. Everyone has gone into powered. So similarly, you can have pneumatic Garrisons. As Naresh Babu wanted me to show that how you should hold it. So this, you should have a complete grip. It should not be, it should be resting on your palm, and you should not be twisting it. So this one is defective. If you twist, you can break or you can catch the dura, especially with tight stenosis or where there is no epidural fat. So you should not be twisting them. So this is the wrong way of doing taking out a bone bite. The Garrison should be sharp, it should be effective, and it should be able to cut bone and ligamentum flavor. So if you find that it is not cutting, it should be discarded. And so it should be at a fixed position when you are opening and closing it. And that's very important. I have seen younger surgeons or surgeons who are starting on try to rotate it and nibble it out. As in orthopedics, we try to nibble out or rotate. So rotation is a common maneuver in orthopedics. But when you're using a Garrison or when you're using a pituitary, please do not rotate, because if you rotate, you may break off the pituitary forceps one wing, and you may get stuck in the disc and you will have a tough time taking it out. So in spinal surgery, both pituitary and Garrison should not be rotated, because in general orthopedics, you do a lot of things on rotation, right from drilling and putting screws, and everything more or less needs a lot of rotation. But when you're using the Garrison, make sure you don't rotate, especially when you're using the thin plate. You may actually break off the plate as well. And I've seen that in hard bone when people try to, and the Garrison has gone a little older, then it may be a challenge. So it's better to change the Garrison than to cause a dural leak or a dural tear. And this is one of the commonest cause of dural tear when you're trying to cut the lamina, inferior lamina at the midline. That is where the dura is thinnest. So this is a wrong way of handling. So you must have a very good grip. So if you grip like this, it's not correct. So that is important. And also it's important that a lot of spine surgeons would get carpal tunnel, hand fatigue. And so it's important to keep that in mind. And so you develop a team where you may not have to do everything and your teammates can do a lot of things. And in the West, it has become almost standard practice to have two spine surgeons operating on major spine cases like deformity, etc., because it reduces your fatigue and helps you, as Ram said, in teamwork, and especially in deformity correction. So care is important. You must always make sure, because the technician may not be making sure. And in big hospitals like ours, we have multiple OT technicians who may not be aware of everything about spine surgery. So you may have a technician who may not have trained in spine surgery or assisted one or two cases and may not be aware of whether the instruments on the set are correct or not. So that should be, you must check your 2 millimeter, 3 millimeter Garrison before you start, rather than straight plunging it into the spine. So I always check and make sure I have the ones which are working. If not, I must get another set, or I have several spare Garrisons which are kept separately, which can be opened up. So that is very important. Also, after surgery, you must, if it doesn't have an ejector, a lot of time bone gets stuck in the sleeves. So you must make sure that the bone is clean and it is functioning smoothly. So the care of instruments also has to be, as we look after our car and service our car, we must also service our spine sets and trays. And that's important. Then there are various modified foot plates available. And I would request all young surgeons, I think mostly it is the young orthopedic surgeons who want to do some spine practice are listening to this session. So basically, you must get your Garrison rongeurs right. You must understand the width, the tapered foot plate, what suits you, what is the bite length, and you must see which, and you must have various types with you. You must have at least a 2 millimeter, 3 millimeter, 4 millimeter upcutting and down cutting, or if not down cutting, up cutting at least, because the you can reverse it and cut distally. And also you must have 1 or 2 millimeters 90 degrees, though it all depends on how you like to use them. If you have a wider foot plate, it deflects the surrounding soft tissues. So that also sometimes helps. So you can have different types. So it's important before you start, you have a look at the various types of Garrison rongeurs, and most of the company people would have all this full range. Sometimes it's very important point, you must not harm any patient. And there are instances of while doing discectomies, you can go anteriorly. So you must be always mentally aware of the depth you are going in, because while you are taking out a disc, the length of a vertebral body will be around 45 to 55 millimeters. So when you are putting in your pituitary forceps, if you go and if you're in trying to take out free pieces, as Ram said, then you may inadvertently, if the anterior longitudinal ligament is deficient, or if you're far lateral, you may go forwards and catch some vessel or catch some abdominal, some small intestine or something like that, and you cause major problem. And once you have a sudden bleeding, you must be very careful, immediately call for help. Don't try to pack and just forget it. So it can be life threatening, and it has been reported. Next comes pituitary rongeurs. They also come in different sizes. And so they have different cups. So you can have biting ones, you can have cutting ones, you can have ones with hooks, or you can have ones with simple cups, and you have different size of length. So similarly to Garrison rongeurs, you have a large variety of pituitary rongeurs which are straight. So the normal ones to keep for a discectomy, which Ram was showing, is normally I use a 2 millimeter straight on anterior. So they are delicate, so don't turn them. And we tend to, if you tend to turn them, you'll break them. So that is important. These are not very cheap. So if you were to get a good one, they may cost somewhere around 40 to 50,000 rupees per piece. So it is important to know how to use this instrument. So have a feel of these instruments and know this. They come in various angles, straight, up and down, and wide teeth and narrow teeth, jaws, as I said. And this. So then the next one is Carb Elevator. I think I don't need to describe the Carb Elevator, and it is very standard, and they come in different sizes. I recently, while one of my fellows were preparing this lecture, actually, he came up with this new combination of a Corb's retractor with the suction. As I think we have seen a lot of suctions with retractors, like Penfield dissector with the suction. So these things are also there, and if you like, you can have a try and see if these help you or not. Nerve root head retractor is a good instrument to when you are doing a T-lift. So suppose, for example, or you're removing a disc which is slightly medial, and I have cut. This is a similar case of a discectomy. So you can you can give your assistant to hold the and then retract the dura carefully and gently, and you can get them straight at different angles or bayonet shapes. So this is also a very useful instrument, and I use this routinely for my T-lift cases where I go from laterally after a facetectomy and then try to centralize the cage. Nerve hooks are important. You can have sharp, you can have round ball tip or round tip, and you can have different sizes of length. So you must, when you start, get the feel, and because the length is also important, the inclination and the angle is also important. So you must have these basic 5-6 instruments. You should have your own set probably, so that you're comfortable with the thing. I'm not comfortable with all the hooks and their lengths and their sizes. So I'm comfortable with only 2 or 3 varieties which are there in my set. And so I would use those or ask for those when I'm doing my surgery. So this is something you have to be comfortable with. Similarly, with Penfield dissectors, they have different thickness, sizes. Some are thin, some are a little thick. And so that also you need to, then the length is variable. and the angle is also variable. So that also protects you, and this is a very, very important instrument to be used. The other thing is we do use osteotomes in spine practice, though these have gradually been overtaken by the burr, by the Midas burr, because now that's quicker. But learning how to use osteotome very close to the spine is also important. So you must have a large handle for better control. And I used to use I use a lot of osteotomes in my fusion practice, especially in Legion scoli or normal scoli. And then you would do all my facetectomies, not by the burr, but by the osteotome. So I normally use a 5 mm or a 7 mm osteotome with a standard handle. On the long handle, if I'm using I always use the microscope. So I use a slightly longer handle so that I can turn and rotate. And so this cuts off bone and preserves bone, and I use the bone for fusion. So this is an important help which is there. Then I think Dr. Arvind is there, and he is a master of these tubular retractors. Two of my fellow colleagues in my hospital also use a lot of these tubular retractors. So they also help because they are less invasive. Tissue access damage to tissues is less, and you need to learn how to use them and angle them because you get a tubular access. So obviously you have to move them around, and so if you want to use this, because the more newer, the young millennial surgeons will have to learn how to do more and more minimally invasive spine surgery, and it is good to get into the practice of using these tubular retractors. You dock in on the lamina, then you start gradually dilating, then you put these tubular retractors, then you drill out the bone or osteotomize the bone, and then keep mobilizing it to go up and down. And if you're using the microscope or the endoscope, you can do in both. So it is quite a good armamentarium to have in your practice. I would encourage all people to learn, because even today I'm trying to learn sometimes using with the tubular retractors. These are standard Norfolk and Norwich retractors, which we have used in orthopedics. We use that in spine surgery also, and these are standard. So they come in various lengths, various hook sizes, and various angulations. And this is a very standard one. And once the jaws get damaged, I think it's important to get it replaced. So this is also something. And you need to release them so that it doesn't cause tissue damage too much. So prolonged retraction causes edema and muscle fibrosis. So it's important to keep releasing them once in a while. The burr is also very, very important, and every spine surgeon who is using a burr should is doing spine surgery should be able to use a burr. A burr has a speed up to 70,000 rotations per minute. So, and it should be used intermittently, at least less than 10 minutes at a single duration, so that doesn't heat up the motor and preserves the motor for a long time. These are expensive instruments. You must know how to handle them and carefully use them. So I would suggest all. Most of the companies would hold sawbone workshops, and the commonest workshop they do is they give you a egg, a raw egg, and ask you to drill off the surface of the egg. And if you're successful in drilling off the surface of the egg without breaking the egg inside with the membrane intact, means you know how to have hand control and focus. So hand control, eye control, and focus is very important in spine surgery. And so this is a routine use. So once you get used to, your hand must rest, you must hold it like a pen, and it should be gentle, and it should be like a brush strokes, not pushing. So there is some difference from general orthopedics, because when you general orthopedics, you are pushing the screw, or you are drilling it with some force, or you're tapping it with some force, because unless you do that, you won't progress further. But while using a burr, you will have to do gentle strokes. The moment you try to push, it will jump, and if it jumps, you can damage the vital structures. As you know, spinal cord is there, the thicker. It takes a second when you're using a cutting burr. There are multiple types of burrs. They are cutting burrs and they are diamond burrs. Diamond burrs don't damage so much the dura when you close to them, but cutting burrs are real tungsten carbide burrs which go at 70,000 revolutions per minute and can actually uh, pick up the roots, and just in a less than 0.1 second you will have the roots in your burr. So it's very, very important to learn how to use it first on a cadaver or on the sawbone. Get your control right, get your focus right, and make sure you're able to see the burr while you are drilling, and then only go in and use the burr. So this is something which will take you at least, it takes my fellows at least 2-3 months. So this is a cervical spine, for example. I'm doing a laminoplasty, and while I'm doing the laminoplasty, I'm making uh, I'm at the spinal laminar facet junction, and I'm making a wedge, a trough here so that I can open from the other side. So this is common, and it's very important that if you have the dura open or if you want to rebirth, you should be very careful you don't damage the dura, and that's also important. So they also come in various handles. I mean, I don't think the time permits me to tell you different handle. There are multiple companies now. Medtronics is the one most common. So they have different handle lengths. They have different sizes. They have different angulations. You must get used to the ones you are comfortable with. I use the angle bar all the time, while my colleague Dr. Kalra used the straight one all the time. So you must know what to use, when to use, how to use, and you have very minimal invasive burrs and handles and long sleeves and short sleeves. So you must have at least 4 or 5 of these handles with you before you start using this instrument. And this is very, very important to learn how to use if you want to do spine surgery. So they have some locking system, they have maintenance. So you must, as a surgeon, I think you must know the full catalog, know which parts you have, which handles will fit what, because otherwise the technician will damage it straight away. Cost around 13 to 14 lakhs with attachment and accessories. So they have different sizes, and every situation demands a different size. And the normal is the matchstick or the round head burr, 2 millimeter, 3 millimeter, or the diamond burr. So they are used differently. Then another instrument is the Masonix Bone scalpel. This is recently been introduced into the practice. It's been there for about 8-9 years, and we have started using it since 5 years, I think. And so this is also is an ultrasonic bone cutter with high speed, and so it is has to have a saline water outflow, saline outflow. So this cuts straight into and doesn't damage the soft tissue. That is the beauty of it. Doesn't generate so much heat if there's enough water, but otherwise it can burn. It can, if you press. This is another instrument you can't press. You have to just gently let it allow to cut. So it has different sizes again. It has burrs and things like that. So this is, as I was showing, the laminoplasty procedure. So we use Masonix a lot in dorsal spine and cervical spine, less so in the less so in the lumbar spine. Then the use of microscope or loop. I think microscope always helps, and though I have the 2 loops, I rarely use. Initially, I used them when I was roaming around different places. But once you have a good microscope, it gives you an illumination up to 10. It gives you a distance to work about 45 to 50 centimeters. So when you choose your microscope for your hospital, make sure it has recording. It has and in front assistance view, so he can help you, and then it takes you along. So but if you use a loop, then it may be a little difficult, but I'm sure a lot of surgeons, I think Ram uses loop, and a lot of people use loop, and most of the American surgeons use loop. So that's why you find the spine instruments are long handled and designed for loop rather than for spine. So that's and also it's important to, since you're using the microscope, then it may be important to protect the lens. So we have a protective plastic cap which comes with these drapes, because they are sterile drapes, and that is important to prevent damage glass. So maintaining this also is important. Your osteotome should not be used near the implant, and so because it may damage the implant, and that is also important to keep. And you never use damaged instruments like this. When I see a damaged instrument like this in my set, I immediately get it changed, or well, obviously I lose my cool a little bit over the technician, because it's primarily his job to check these instruments. I think Ram has already spoken about patient positioning, especially in prone position for cervical spine procedures or even lumbar spine procedures. All our procedures more or less are on the prone position, and it's important to do 2 things. Make sure the patient is positioned well, make sure the abdomen is free, make sure the legs and the bony points are well padded, make sure the C-arm is coming in the position, and check the C-arm before you even start positioning or start operating or draping, because once you later on you can't do any adjustments because you tie them up. or attach them. So it's, and sometimes you must be aware that you may not be seeing AP view of in all situations, and you may have to manage with the lateral view. So those things have to be kept in mind. A lot of planning has to go before. So your fellows or yourself, if you're doing everything, must go into each of this, because you are responsible. It's a patient-doctor relationship. Though it's a teamwork, but at the end of the day, you are the captain of the show, and you as a captain have to be a team leader, inspire them to do things correctly, or make sure that you have a quiet eye on them, notice everything as Ram said, and be meticulous in it. So we have different ways of going about things, and we have modified, and every situation you modify yourself. And this is also an important, I thought I would share this. We have a complete set of this. This is from the hardware store. Sometimes different surgeries from different situations and different places of the country come to us, and we find suddenly we are not able to take out a pedicle screw in a revision surgery, but this set can actually remove any sort of pedicle screw. So such a set can be helpful in your practice. And this is just a local tip, and I found these are available in very good quality stainless steels, and so you can autoclave them and keep them also. So when you're using a pedicle probe, especially a lengthy probe, I've seen a couple of fellows or myself actually damaging the probe by, if you try to rotate the curved pedicle probe, then you may break off the tip. As you can see, it is broken off. The tip is broken off. This is a case of Angstpond, so it is stiff. And while I was trying to make a entry hole, the pedicle probe broke. And that is not a nice thing to have here. And the patient can ask you, and you must counsel the patient that you have got it done. And all your instruments should be well protected, because the commonest problem is that in a prone position, you tend to keep the instruments on the patient's back or thigh. So there's a magnetic pad we have, which is not shown here, which prevents the instruments falling, because you may not have many sets available for you to get another set. And then our technician uses these whatever micro shield bottles and cuts them, and we keep all our instruments inside, so it's well protected. Bone wax also, there are methods of giving bone wax, and you must train your technician. I like them to be given when I'm trying to plug holes, to be given in this way and not on a peanut, but you may have to use a peanut sometimes. So you must have different options available when you're using bone wax. So you can't take your eye off the microscope or the loop. The technicians or your assistant must know how to give them to you. And that is also important. So these are the few tips that I thought I could share, because when Naresh told me, sir, you have to show how to use a Garrison and a pituitary. So I was a little surprised, because I've never given a talk like this before, because this comes natural to a surgeon. And in my training ever, nobody has told me how to use an instrument. So it was nice of him to ask me to talk, but I don't know if I hope I have taken you through this gamut. I'm happy to answer any questions or show any other instruments, anything, anytime. He asked me on Thursday, so this is what I have managed to prepare. It was first time giving a talk like this. Thank you, Naresh.
Thank you very much, sir. Thank you very much for obliging in a short notice. That was a wonderful lecture. You can unscreen the screen, sir.
Okay, sorry, my apology. Stop sharing.
Very small discussion. Ram sir, you want to add anything? That was a wonderful talk we had from Dr. Shankaracharya sir. Anything to add from your side, and how any tips for the general orthopedic surgeons while using these instruments?
A small tip. It's a fantastic collection of all the experience that Shankar has shared. Something that one of my seniors taught me, and I have tried my best to share it with everybody. Whenever we use the Garrison ronger, and especially when we are using it in the lateral recess or on the roots, please try to use the ronger parallel to the root. Never use the ronger across the root. So whatever you do, you will be parallel to the root. So that means if the root is getting off at around 45 degrees, your Garrison needs to go parallel to the root in the lateral recess. This is one way of keeping that root, especially in the elderly tight canals. So this is a small tip just to use the instrument.
Correct,
and
correct.
I have sort of learned it, and I love to pass it on, because I have seen people really pick off roots and have major root injuries.
Good morning.
Gautam has nothing more to add.
He has to say something. Just before Gautam says something, I want to say I don't know, Gautam, if you saw Ram's lecture, there was two people where you said it was to be indulgent. There were two team players, and Gautam is my secretary of ASSI, and I'm very glad to say that he is one of my best friends who's both indulgent and critic. And so before Gautam says, I thought I would say this pitch. Welcome, Gautam.
Yeah, so there are two things that I would like to add for orthopedic surgeons or young trainees. The first is to develop the strength in your grip, because when Shankar mentioned that a lot of boys tend to twist when removing the bone, part of it is because the instrument is not sharp enough, but part of it is also because you don't have enough grip strength. You need to work on your grip strength in order to be able to do this work well on a consistent basis. The second very important thing is to learn to use if you're a right-handed individual, learn to use your left hand for the Garrisons, etc., so that you can work around corners on the side on which you're operating, etc. When I was a trainee, I was completely right-handed dominant, could not use my left hand at all. And my boss told me this is not acceptable. So what I used to do is sit like a cobbler in the evening with the bone model between my 2 feet and actually use the Garrison with the left hand. Now I won't say that my left hand is as good as my right hand, but I can very effectively and it is quite functional. And that is extremely important, to be able to use your Garrisons with both hands.
Very good point, I think.
Arvind, you want to add anything for this? Arvind, you use a lot of minimal invasive. Do you do something differently because you don't have that field of vision?
No, I agree with all that has been spoken before. What Gautam has said, the use of left hand, what Ram is, widely accomplished in his talk, and Dr. Shankaracharya. I follow the same principles.
Mukhabhadhyay, sir, you want to add anything? You are muted, sir.
No, this is I have nothing to add. This is a very fantastic session going on, and I'm still thinking of Dr. Ramchand's lecture. This is a very good. I will ask all my residents to follow this in orthopedic in the future, who wants to become a spine surgeon in the future. It's this session is going on very fantastic, and the speakers are well known, and they are very fantastic lectures. So I have nothing to. You can continue with the session.
Thank you, sir. Thank you, Shankar sir. Please stay back if you can. And next, we will move on to Dr. Gautam Zaveri, speaking on how to avoid wrong level surgery in spine. One of the dreaded complications of spine surgery is wrong level. Sir, over to you. You can start sharing your screens. So slides are visible, sir. You can start. Sir, you are muted, sir. Please unmute yourself. Yeah, now we are able to hear you.
Sorry about that, Naresh. So as I was saying, John McCulloch, who is widely regarded as the pioneer of microsurgery within the spine, described 3 cardinal sins in spine surgery. The first is operating on the wrong patient, where he emphasized the importance of patient selection. The second cardinal sin is that performing the wrong operation on the right patient. Now you have chosen the appropriate patient, but you need to select the correct operation. There is a lot of fancy operations which are coming in, and sometimes these may not be most appropriate for your patients. And the third one is performing the right operation, but at the wrong level. And this is what we are going to talk about today: wrong level spine surgery. The US Joint Task Force for Prevention of Complications during surgery has labeled wrong level spine surgery as a never event. A never event is an event which is completely preventable and occurs because of some overlooking or some mishap on the part of the doctor. The incidence of wrong level surgery varies between 0.15 to 2%, but this is supposed to be widely underreported. In a survey of 415 neurosurgeons belonging to the American Academy of Neurospine Surgeons, they reported that 50% of them had performed one or more wrong level spine surgery. In fact, it is thought that 35% of orthopedic surgeons will perform a wrong site, wrong level surgery sometime during their 25-year orthopedic career. Wrong level spine surgeries are very common within the lumbar spine, but that probably reflects the fact that most common surgeries are within the lumbar spine. Thoracic spine surgeries probably are the most difficult in terms of level isolation or identification. The most common wrong level is usually the immediately cephaloid one. 68% of wrong level surgeries are noticed intraoperatively and remedial action can be taken then and there. But 27% of patients, the error is realized more than 24 hours of the surgery, and this results in a lot of embarrassment for the doctor and often malpractice suits. Wrong level spine surgery, if you have done, malpractice suits are unforgiving, and 84% of the time the suit is settled in favor of the patient. So what are the causes commonly of wrong level spine surgery? The first and foremost, which is what Ram emphasized in his lecture, is the failure to obtain preoperative X-rays. Today, patients walk into your clinic with an MRI scan and we identify the pathology and go ahead with surgery immediately without getting a preoperative X-ray on occasion. What happens here is there are often transitional segments, sacralization of the lumbar vertebra, lumbarization of the sacral vertebra, or fused segments which lead to wrong level identification intraoperatively. The third problem is failure to confirm the side on which you want to operate. There have been times I have also been guilty where in my hurry to start the surgery and patient has a right-sided lumbar disc prolapse and I've just gone in and stood and started left-sided exposure only to realize later, oh, I've exposed the wrong side. So it is vital that the side and level should be confirmed preoperatively. The most common wrong levels, I feel, are within the lower cervical spine, where visualization is difficult even with proper imaging, and within the upper thoracic spine. The rest of the thoracic spine is vulnerable to wrong level surgery when the pathology is like a disc prolapse or an intravertebral tumor. The vertebral body contour is normal. Another big problem is inadequate intraoperative X-rays. This could be because of you don't have a good machine, you do not have an appropriately well-trained technician, if the patient is not properly positioned, and of course there are certain anatomical hurdles like obesity, scoliosis, osteoporosis when the bones are not clearly visible, or few segments in the spine. And finally, of course, are wrong surgical techniques. Let me elaborate a little bit on this. The first of which is inadequate patient positioning. If you have a horseshoe headrest when you are positioning for the cervical spine, often you will not be able to take a good AP view because the metal will come in between and block your AP view. So when you operate at C7T1 in these patients, you may not be able to adequately identify the level. Inadequate surgical exposure, if you have not adequately exposed the spine, there is a lot of muscle left there, there is a lot of bleeding going on, you may land up operating on the wrong level. A lot of people rely on the skin marking. They mark the skin before starting the surgery, and they rely on that to identify the surgical level. You must remember that the skin is mobile, and therefore once you expose, you may still end up at the wrong level if you rely on that marking. Some people rely on the counting of ribs to identify levels within the thoracic spine. It is difficult to count ribs, and there may sometimes be anomalies where one or more ribs are absent, and you may ultimately end up going to the wrong level. Again, some people after exposure rely on checking the mobility of the L5S1 segment. What they do is they use a nibbler, hold the L5 spinous process and move it. And if this is the first mobile level, they can think this is L5S1. They may land up in problems if there are transitional segments. McCulloch described what he called as the laminar trap. Let me elucidate it a little further. And the final problem with improper technique is lack of suspicion when you operate and you land up not finding the things which you had seen on your preoperative X-ray and MRI. In this case, you should be suspicious and get further X-rays intraoperatively. The laminar trap, as described by McCulloch, is a situation that when one ascends up in the lumbar spine, the cephalad lamina overhangs the disc space more and more. This occurs even more when the disc space is collapsed. So if you put a needle looking at the disc space straight down, what happens is you actually may land up on the cephalad lamina. And after exposure, you may follow that lamina upwards and be directed into the disc space above. And therefore, in the lumbar spine, the kyphalad level, the level above the pathology, is the most common wrong level surgery. So how does one prevent wrong level surgery? I think the key is just meticulousness and obsession. As Dr. Shankar mentioned, you are the one responsible for the patient's well-being, and at every step of the surgery, you must make sure that you are in the right place, doing the right thing for the patient to prevent problems. So what we do here in our hospital is that we mark the level and the side of the surgery before the operation. When the patient is in the holding area, when he's not yet sedated, you ask him which leg is painful, confirm it with MRI, and draw an arrow on that leg so that you know that this is the painful leg. Intraoperatively, before the patient actually you start the surgery, the nursing team does a timeout where one again confirms the level. Always obtain preoperative X-rays. Match your preoperative X-ray with your preoperative MRI. Remember that intraoperatively you are going to see you are counting levels from below upwards under Siam control, which is an X-ray. So you must identify last mobile segment on your preoperative X-ray, and based on that, you look at the pathological level. Typically, most radiologists count the vertebrae from above downwards on their MRI, and accordingly, they write L4-5 stenosis, whereas on your counting from below upwards may actually be L3-4 or L5S1. So therefore, always match the level and say that when you are operating, you're operating on the second last mobile segment rather than saying that I'm operating at L4-5. Preoperative level marking is something which is very useful. Some people to use an immovable marker for thoracic pathology or even in the lumbar spine. They put a needle into the cephalad spinous process, and once the level is confirmed, they cut off the needle at that point and remove the needle intraoperatively. When I was in England, what we used to do is send the patient preoperatively to the radiological suite, and the radiologist would inject methylene blue into the ligamentum flavum and the interspinous ligament, so that when you expose, you could see the dye and know that you are at the right level. This is especially important and useful in thoracic pathology, or when you are suspecting that patient we may not be able to get good quality intraoperative X-rays. Proper positioning and adequate exposure has been amply dealt with. Good quality intraoperative imaging is vital. I will not do a vertebroplasty on the day that my radiology technician is not there. These are procedures which are completely technician dependent, CM dependent, and you must have good quality imaging in order to be able to proceed safely with surgery. Routinely, you must confirm levels not only at the level of skin, but after exposure, you put in a Penfield 4 below the lamina and check the level. And again, at the end of the surgery, put in a probe into the disc space and check the level. If there is any mismatch between what you are expecting looking at the preoperative MRI and what you are finding intraoperatively, do a recheck imaging. So finally, to end with, how do I prevent wrong level surgery in my patients? I always get preoperative x-rays, both AP and lateral view. I spend some time comparing these AP and lateral views and finding the pathology on the MRI so that I know precisely which level I am operating on intraoperatively. Always talk to the patient before induction, find out the pathological side, the pathological level, you confirm it in the holding area and check his chart so that you know you are not missing anything. When you are inserting a needle, don't try to insert the needle opposite the disc space. Instead, try to insert the needle between the two spinous processes. When you do that, you are exactly at the level so that in this way you will avoid the McCulloch laminar trap. You then follow the lamina upwards into the disc space. Once you have exposed adequately, put in a Penfield 4 below the lamina or use an Ellis if you have exposed bilaterally and confirm the level. If there is any mismatch between intraoperative findings and preoperative imaging, check again, put in a probe into the disc space or into the laminotomy defect and make sure you are at the right level. To conclude, I would like to end by saying that wrong level spine surgery is almost unforgivable. And it is usually a surgeon error, either it is surgeon fatigue or the surgeon has not been careful, he's in a hurry, and this usually results in the problem. There is very little excuse, and the courts certainly do not forgive surgeons who do wrong level surgery. So beware of that. Thank you very much.
Thank you very much, sir. That was a wonderful lecture. How to avoid wrong level. Any more inputs from the other faculty? Sir, if you I have one small question. So if you have encountered and ended up doing a wrong level surgery, so how do you tackle with the situation?
As I said, it is extremely embarrassing. It's very difficult if you ever have to do it. But the best way to tell them is honesty. You talk to the patient, talk to the relatives, and explain to them that this such and such a mishap has occurred. You accept the onus of responsibility. You say that there has been a mistake which has happened. You don't have to be completely brutally honest in this case. You can say that the level was the imaging was not very good, or you can say that the osteoporosis was there, so it was not very clear, or because of obesity or because of scoliosis, and try to correct your mistake as soon as possible. In all these situations, it is usually very useful if you can involve a senior colleague of yours and get him to come in and give a second opinion, because when he or she talks to the patient as a neutral second opinion, then the patient is more inclined to believe this and is more ready to take remedial action. Another thing which you must understand is that if you have done a wrong level surgery and you are going to correct it, please do not run after money for.
You had some problem with Gautam sir's audio. Shankar sir, anything to add on to the
Yeah, I mean, I have a couple of checklist system. First is if it is a fixation, we always check final C-arm and make sure that we are satisfied. If we do not feel, and if we want a longer picture, then I get the mobile X-ray, which is always there in our theater to get a mobile X-ray. But a C-arm shot normally provides me enough evidence that everything is perfect. Recently, I did a Angst case where it looked to me in the C-arm that the reduction was all right. But when we took the final X-ray, I found that the reduction has slipped. So immediately I redid, the patient was extubated, I redid it. The other thing is that you always check thrice. As Gautam said, wrong patient, wrong level, wrong patient and wrong surgery. So wrong level is very, very common. And so you will check once when you mark the skin. Then I have a system of using a Garrison ronger to put under the lamina. So I know the direction of the disc it is pointing to rather than a pen-filled dissector, because that is smaller incisions. It is much better because so I use a routinely a Garrison ronger to show me the direction. And after I have done the surgery, if at all I have any worry or doubts or was not happy, as Ram said, of taking all the fragments out, I would put my pen-filled dissector in the disc again and check. So I checked 3 times to be honest. And in any fixation, I would check the final C-arm picture. And before the patient is extubated, because I may have left the room, the fellow's duty is to send it to the group, since WhatsApp has come to our theater group where I would be able to see it. Suppose I've gone after the OPD, I would be able to see and I'm okay. If there is any suspicion, I would immediately ring them back to say that look at it this again. And if anything is required, I would go back. So these are sometimes checklists. I have one confession many years ago where it was early in my practice. Once you do a T-lip case, I did a L45 fixation and I put the cage in L3. And it is inadvertent because if you have a smaller incision, you can do that and you can cut the wrong facet. So that is also very important because the spinous process is downwards. And when you're cutting the facet, it is important to cut the facet rightly because sometimes the facet may invade, the one above may be cut. Obviously, there was no issue, but I was frank to the patient that I added a level because I had cut some bone inadvertently and did a double level TLIF instead of one level TLIF. And that's so. The other thing I do is if I have a dural leak, I inform the patient immediately post-op. So that is one situation. Or if I have a dural leak or if I have a neurological deficit, I call the patient to my theater outside waiting and then tell them, look, I have a problem. There is a dural leak. This is the next steps. So I'm quite frank with them. And since I work in a big hospital, it's not a big issue. But medical illegal cases will happen, and any surgeon who has a large volume and you will have some cases. So you have to be very careful. The other thing is documenting it. So as soon as you have a complication, make sure you document it with 2 spine surgeons of your unit or 3 spine surgeons of your unit. Get documentation done immediately at that time and the same time. Because a lot of patients may then take a photo from the camera or whatever, I don't know, but these things are happening. So I have always advised my fellow that the moment there is a complication, you must write in theater notes that there has been an inadvertent leak of dura. This is how it has been dealt. We stitched it with 60 Prolene, or we put our dura gen on it. And then the post-op instruction should be accordingly. These are the situations where I handle the complications like this.
Thank you, sir. So anything to add from Ram, sir?
Well, one, with the minimally invasive guys coming in now, the added advantage of minimally invasive, and I'm sure Arvind will agree with that, is that the incidence of an inadvertent wrong level surgery has significantly reduced because it begins with placing your basic tube in there. So most of them don't go wrong because they placed the tubes correctly and seen those images multiple times. Another small thing which you can practice besides checking the level thrice, which is on the skin before opening the ligamentum flavum and afterwards, in case you don't find the disc, is something that we practice as a routine. Have a printer attached to your C-arm and see to it that it is working. What I mean by this is, I always take a final printout, placing an instrument from where I did the discectomy. Suppose I had a level 1, level 2, or level 3 McCullough's levels that you have above, at, or below the level of the disc. I put my ball tip probe, the 90-degree one, and take a shot as to where the disc came out from. Once you've taken that shot, you have the evidence that you are on the right place and you've done the right surgery. So the chances of your going wrong is much less when you take that printout. So just keep that at the back of your mind. You have a printer of the C-arm, take a C-arm shot, get a printout and check it. That's all.
Arvind, you may be having less wrong levels, but wrong side is still possible in...
Yeah, so wrong side is still possible. So it has happened a couple of times. And the good thing is, this good or bad thing is it happened after doing the laminotomy. And the beauty of the tubular retractor is you can actually, if you excise the flavum, you can just suppress the dural sac a bit. And if you've done deroof the inner cortex of the opposite lamina, you can actually conveniently put in a nerve hook and remove the disc from the opposite side. But this, you should do after a good amount of experience. The other thing is, as Dr. Ram said, this is one of the blessings of minimal access, because the tube is so robustly docked, after tightening the table attachment and the nut attached to the tube, that it doesn't move. You try to shake it, it doesn't move. So the incidence is close to zero. I think we have a publication on this in Journal of Minimal Invasive Spine Surgery and Technique. It is not PubMed indexed, but highlighting the same point.
Yeah. Thank you very much, Gautam sir. That was a wonderful talk. We learned a lot from that, and you stay back, and then we'll move on to the checklist in spine surgery, how to do the spine surgery safe. Small introduction with this. I think Arvind has developed this one and got published in Asian Spine Journal. I learned that he recently got an award also for safety in spine, safe spine surgery practices. Congratulations, Arvind. Please go ahead with your lecture.
Thank you, Naresh, for this kind introduction, and thank you for the invitation. So checklists form the core or the spine of any big or small enterprise, be it flying on the aircraft or planning your holiday. In fact, today's meeting, the planning, execution, as well as relay, the triumph of this goes to formulation of a checklist. So what do checklists do? They help in achieving success and preventing failures. They cover for the weaknesses of human memory and forgetfulness. What do I mean by that? I'll give you a small example, hypothetical example. Your cook has come late, you've not had breakfast, your driver has not come, it's raining heavily, you have a new resident and you're doing a discectomy, you go into a wrong level discectomy. And the reason is not that because you're not intelligent, not that because you're dumb, not that because you're done your MS in the best, orthopedic training center in India. It's just because your mind is clouded by non-essential things. So these things interfere with your working capacity. So it is best to bring plans and execution to paper and pen. So that is what the checklists do. They increase the efficiency by adopting simple steps. These are basically ticking against a task. So checklist is no more a phrase limited to doctors and hospitals. It has become a catchphrase, a household name in all societies. We follow checklists all the time before leaving our houses. So talking about hospitals, you'd be surprised that, majority of adverse events that take place in the operation, the majority of adverse events take place in the operation theater in a hospital, and close to 50% of these can be prevented. And you'll be surprised to know that 1 million out of, so we'll be surprised to find that we, in general, overall in the world, we operate in 234 million people every year. And 1 million out of these die because of complications. And 50% of these complications are totally avoidable and happen because of negligence. So why do complications occur? Has expertise failed? Have super specialists failed? Have expensive medicines failed? Have sophisticated devices failed? Not at all. It is just the cloudedness, oversight, overconfidence, passive approach, a casual approach. So adapted from this popular book by Atul Gawande, The Checklist, So these checklists do not teach you how to operate a complex case of scoliosis. Instead, they provide reminders of only the most critical and important steps, the ones that even the highly skilled and highly intelligent surgeons using them could miss. So why do complications occur? These are all the reasons: experience, fatigue, workload, etc. But the most important is, communication gap. If you can optimize your communication gap, you can really bring down your complication incidence, and that can happen with a checklist. So surgery is like an orchestra. To save one life, scores of people must perform 1,000 things correctly and simultaneously. There should be synchrony. So there is, do checklists work? So there is striking evidence that the WHO checklists work, especially in low and middle income group countries. Reduced infection rate by close to 50%, reduced death rate by about 50%. And at the gastrointestinal level, that comes from Dr. Shankaracharya's hospital, it is shown that it is beneficial. So when we have a WHO checklist, why reinvent the wheel again? Why formulate a new checklist? Because spine surgery is exceptionally exceptional, because there are thousands of things happening here. So it is a zenith of permutations and combinations. So we have gone through this in Dr. Ram Chadda's and Dr. Shankaracharya's talk. So there are, when it comes to spine surgery, there are so many regions, so many junctions. Then there is left and right. Then there are different kinds of operations, whether you're fusing or just decompressing. And if you're decompressing, do you need a microscope or not? And if to check the level, you need a C-arm. And if you are instrumenting it, do you need a navigation? And again, there is front and back. And you need whether you're going to use bone cement. So there are 110 things, which need to work in tandem for a successful accomplishment of a surgery. So these are the things which are clouding the surgeon's mind, for a particular surgery. And added to it, he has to prepare for a weekend webinar, talk. He has to give another talk the week later on. He has to teach his fellows. And there is a complication that has happened previous night. And one of the most prominent fellow that he depends on is on leave. So in such a situation, there is a tendency to forget things and, skip, miss things and end up in complications. So necessity is the mother of invention, it is said. So this this goes back a long time before, circa 10 years back. So this patient with cervical myelopathy underwent en bloc laminectomy, and there was uncontrollable cluster bleeding. Cluster bleeding means bleeding at various sites at the same time. It was impossible to control the bleeding. To top it all, there's no grouping and cross-matching done. And this patient ended up in an intraoperative death. This is unpardonable. Again, this is a very common situation. You don't have a rescue implant in the operation theater. So you have a compromised fixation. Otherwise, if you don't do it, and if you're waiting for the implants to come, you're wasting your time and exposing the patient to infection. And on two or more occasions, we had this tubular set. So Dr. Shankaracharya was talking about this tubular surgeries. So I have my own set. As he said, most of Bombay surgeons, they go from one hospital to the other. And it happened a couple of times that this tubular set, which you generally use for minimal access surgery, was missing. So I ended up doing a micro discectomy instead of a tubular discectomy. And this is a very silly excuse. So what do these examples tell us? That we need to have a pre-operative checklist to organize blood, to see to it that the instruments are in place, etc. Again, as Gautam highlighted, wrong level surgery is a sin. Okay, so hence we need to have an intraoperative checklist that such issues are not, such issues don't happen, such bad things don't happen during surgery. And then most importantly, this is the phase, post-operative phase is the phase of complications. This is the time you realize that patient can have problems, especially after discharge. So patient is totally unaware. So, this is a patient who had decompression done. After a week's time, patient started having discharge, and this discharge was not alarm to the operating team, and the patient came with a full-blown meningitis only to die after a month. So these are very, very relevant. So that is why our checklist has 3 components to it. So there is a pre-operative checklist. So this basically underlines this particular statement, that is, all battles are first won in the mind. So you need to go through the entire surgery, that much time, quite in an advanced time, so that you don't go wrong while in the battlefield. So intraoperative checklist deals with components which are specific to spine surgery, along with the components of WHO checklist that starts right from identification of the patient and identification of the site. Then comes this phase of complications, where it's very, very important to recognize complications and treat them. So this is a 37-point checklist. So the best way of implementing it was to check with the year before the complication incidence and rate which of the year earlier, and compare it with the current year. So we saw that phenomenal reduction in preventable errors was palpably visible in the after following the checklist. This is after being a very, very vigilant unit. So these are some of the components of the checklist. Components of the complication that we checked after following the checklist, and there was as I said, 75% reduction in the complication rate. And following a checklist is not something that is new to us. We have always been following a checklist, whether it is a pre-operative, pre-anesthetic checklist shown on the left side, or a checklist in response to an intraoperative neuromonitoring changes in a patient being operated for a deformity, etc. So especially in our situation, why a spine surgery checklist makes sense. That is because there is a lot of stigma associated with spine surgery, and we carry this negative tag all along, that is failed back syndrome. So we need to to increase confidence, to generate confidence, we need to deliver good results, excellent results. Again, the kind of complications that we face are irreversible, unpardonable. Patient can end up with monoplegia, paraplegia, etc., and also death. So again, we all know the cost of treating a complication is much higher than the cost of a primary surgery. Again, the kind of situation that we are in, even in the best of hospitals, our OT boys and nurses are not very specifically trained for spine, and we experience a high volume of surgeries, and the the resources that we are exposed to are very limited and bizarre. For example, we are about 50 spine surgeons in the city of Bombay, and there are just 3 or 4 neuromonitoring machines, which make the ratio totally unacceptable. And again, we don't have stationary inventory in our operating theaters. They're all placed to order. So there is a possibility of not having, bailout implants at hand. And our fellows, residents, they keep changing all the time. And most importantly, we don't have a good GP surgeon algorithm for them to manage or even inform us about complications. So that is where the checklists, come in. So they bring discipline. So for example, post-operative, if you, in detail, you explained the red flag signs and ticked it, that you've done it, it can rescue a lot of patients from being neglected if they, face a post-operative complication, for example, the patient with meningitis. Again, they give you guidance. So when you're going through a checklist, if it's your if it is your resident or if it is your fellow, when he goes through this, he'll start thinking. So for example, a bailout surgical plan. Okay, what would be the bailout surgical plan for a loose S1 screw? So then he starts reading. So it could be a bigger screw, bigger diameter screw, longer screw, or, you'll have to go to the pelvis. So if you have to go to the pelvis, what are the options? So it kind of generates reading and knowledge in that particular resident or fellow. Again, same thing with graft. So if there is no local graft available, if the iliac crest has a problem, the hospital doesn't have allograft, what are the types of graft extenders that you can use for that particular surgery? So checklists give a lot of, they stimulate you to think and guide you. Again, in decision making. So, so you've posted a patient for decompression, the microscope is busy, someone else. So if you're not thought about it, these checklists come as a, as a night watchman, and they just pat you on your back and tell you, brother, have you checked whether microscope is available or not for this particular case? So these are all very minor but important things. So this is our comprehensive, checklist that we follow. And being having the luxury of multiple fellows, one fellow is delegated to filling this up on a routine basis. So as Naresh highlighted, this particular checklist probably forms the first comprehensive checklist in the world for spine surgery, and it was awarded one of the top 10 best new methodologies and techniques to enhance safety in spine surgery awards recently. It's got published online. So checklists allow surgeons to concentrate on non-mundane stuff. A checklist is the application of the knowledge we have consistently, correctly, and reliably. It's nothing new. It is just application. Checklist helps in making things correctly. Checklist shows that each problem has steps of solving. Checklists show that each step is important. Checklists show that the more you repeat it, the more you master it. Checklist reduces error making, reduces complexities, offers the possibility of verifications, establishes effective teamwork. So there is clear distribution of responsibilities. They help in effective utilization of resources, skills, improvising the provision of quality services, because customer is the king, and they provide you reminders of the most critical and most important steps. So to conclude, this is a new spine surgery checklist, which is very efficient, reliable, and cost effective. Of course, initially there is a learning curve to it, but we have gone through it, and it's very simple and easy to follow. It is subspecialty specific only to spine, and it reduces miscommunication among primary. So there are a lot of things which are assumed, taken for granted in the surgical team, and suddenly, it is not the more the merrier. The more the fellows you have, the more confusing it is. So it helps in preventing miscommunications, because someone is responsible for filling it, and that basically helps in executing it and leads to a successful outcome. So again, there is enough scope to customize this particular checklist to your own local milieu. Thank you.
Thank you very much, Arvind. That was a great lecture. And I think every institution or every surgeon has something methodologically planned in his own mind. This puts it on paper and makes our lives very easy, and also teaches our fellows a systematic way of going forward. Shankaracharya sir, Ram sir, Gautam sir, anything you want to add? How do you manage this checklist in your center?
So let me start the ball rolling, and by congratulating Arvind for a fantastic work that he has been doing in setting up this, and this is very essential. I think there are 2-3 things that which need to be highlighted. To avoid complications and be a good surgeon. A lot of times we have talked about being born as a great surgeon, but good results come not necessarily from being a great surgeon. They come from being obsessive and compulsive about every aspect of patient care. Right from the time you have seen the patient in the clinic, and the emphasis that Dr. Chadda gave on patient selection, taking care of the patient's mental condition, etc., to the time when you actually select that patient for surgery and then start planning all the other things and paraphernalia around it, which Arvind mentioned, to the points which Shankar mentioned, where you have to use the instruments, proper instruments, and taking care of those instruments in a proper way. What I recommend to my junior residents, and which I always tell even general orthopedic surgeons, that in your surgery, step 1 to step 100 should be the same every time. That reduces errors. By following the same steps, not only are you less likely to make a mistake, but your team knows what is going to come next and is able to help you with the further process. I can give you an example. There was a time when I was operating in a new hospital. I'm talking about 20 years ago. It was the first time I was operating there, and I was just simply doing a micro decompression. Normally, when I do a micro decompression, we just use the McCulloch retractor. On that day, with the McCulloch, I was not getting as good an exposure as I wanted. And so I shoved in one gauze piece above and one gauze piece below in order to get a little bit more of muscle retraction. Because this was not my normal thing to do, when I finished the surgery and I was in a hurry to close up, I forgot to remove the gauze piece. And this patient had a retained gauze piece. Luckily for me, because as I said, I follow the same protocol with every surgery, I remembered this within 48 hours and I realized that I had forgotten just thinking about the procedure, I realized that the patient had forgotten a gauze piece inside. And I explained to the patient, and within 48 hours when doing the dressing and removing the drain, I opened up the wound and was able to take out the gauze piece. So if you are doing your surgery in a stepwise fashion, you will remember the mistakes you have made and you will be able to correct them. So try to develop protocols of even surgery. What step you are going to do next? What is the time? How much exposure is required? How much is sick? The other thing which Arvind mentioned was the checklist. In a sense, most countries have got surgical pathways, beautiful pathways which have to be filled in similar to his checklist for each aspect of the surgery. From the time the patient is admitted, whether his investigations are there, and different people are supposed to fill up different parts of the pathway, whether it be nurses, whether the physiotherapist has come and done the exercise, and those pathways are certainly worthwhile following in addition to what Arvind has said. So obsession, meticulousness is what makes good surgeons better, and it contributes to great results. So if a person is obsessive if there are times when you are closing and you may find the skin is not really approximating that well, it is probably better to cut your stitches and redo the suturing rather than accept a really poor result. Thank you.
Thank you, sir. Shankar sir, anything to add from your side?
All of the things have been said, and the importance of checklist is so important that in the theatre book for spine surgery, which we are making, I have put Arvind Kulkarni in charge of the first chapter, and that's theatre book as a checklist in spine surgery. So that is so important that it cannot be, it has to be underlined. For us in spine surgery, we have to be careful right from start to end till post-op outcome.
Ram sir, your final comments.
I really am most impressed by the checklist and the way that we should implement it. My humble submission, and that goes to all who are seated here. These are all people who are leaders and who are having the vicarious responsibility of their entire team. The purpose of the checklist is to make a process which protects them. Because as Shankar mentioned, as Gautam mentioned, as Arvind mentioned, the ball stops with us. Means we can't put it into anybody else's court. The patient is ours. So we have to create this in the entire team, where the entire team covers our back. Filling the checklist is one thing, but having the guts, as Gautam did, of stepping up 48 hours later, talking to the patient, that has to be created in the entire team. please make it very clear that even if somebody has filled the checklist but feels at a later date that there was some disparity or dispute in their mind, you create that power distance index to be as small where even the junior most resident or a fellow can step up and tell Arvind or step up and tell Gautam that, listen, I feel that this probably was misinterpreted by me. And that is what is going to reduce your complications and adverse events. So that gap which is there between the mentor and the mentee has to be reduced. And only then will we be able to avoid complications and adverse events, which is very critical in spine surgery. None of us can become individually great. The team has to be great. And the team has to believe in the same thing, that every person owns the patient. From the fellow to the top guy, they all own the patient. That needs to percolate down. So that's where I have to come in and say that it's something more than just the process. It's creating that purpose-driven, passion-driven profession. That's all.
Yeah. Thank you, sir. So thank you, everyone. That was a great lecture and thought-provoking.
So I want to make a point. So I want to highlight the point Ram spoke about in his talk. You should have one good critic in your team. सब हाँ में हाँ मिलाने वाले हैं, तो you'll end up in complication. And you'll make certain that even if he's somewhere in the clinic and if your pedicle screw, if you're not very sure where it is, you will ignore all the rest. You will call them from wherever he is and ask him once, do you think it is in the right place? So you need one good critic in your team.
Yeah, genuine critic. So it was from the spine subcommittee. I would like to thank all the faculty for taking time on Sunday and morning and making it successful. I feel it's a good start for the IOA spine webinar series. On behalf of spine subcommittee, myself and Dr. Mukhopadhyay sir, and then Dr. Sarkar, and advisors Dr. Shankaracharya, President of ASSI, Gautam Zaveri, Secretary ASSI, and Vishal Kundanani, member of committee. I wholeheartedly thank President Dr. B. Shankar and Secretary Dr. Naveen Thakkar sir. Naveen sir, are you online? Thank you very much for giving us the platform to spread spine knowledge across country to the orthopedic surgeons. I also like to thank Dr. Ashok Shyam for giving us the technical support, and Dr. Shamshul Huda from IOATV and Ortho TV for making it possible. So thank you very much for staying back, and it was a great start, and I thank all the speakers for taking time. Sir, you want to add anything, Shankaracharya, how we want to take it forward from the...
I think this is a great initiative, because it is my concern that a lot of orthopedic surgeons tend to shy away from spine surgery purely because of the anxiety, the fear, and the ability to handle neurological tissues and things like that. And trauma seems easier and more reproducible. And what is happening is, even I see that we have 24 orthopedic consultants in my hospital, and ultimately it's only us who are doing the spine surgery, which is not good. I have initiated a system of ortho residents coming on rotation to spine surgery unit, so they get the basic. And every spine surgeon will not be in metropolis, and as grade B and C and tier 4 cities come up, as orthopedic surgeons, we have a responsibility towards the patient. We are on the top of the pyramid. It is our responsibility to train, teach, and educate our orthopedic surgeons. And I would encourage Professor Shiv Shankar to help us to spread the knowledge of spine. Because as you know, as a president of ASSI, I get a lot of letters and messages from orthopedic surgeons that a lot of packages that are there in the government or in the states are focused on same spine surgery could be focused on a neurosurgery, and you may have been necessarily to keep a neurosurgeon just so that the package regulations and rules can be substantiated. This can only happen if more and more orthopedic surgeons get involved, learn in spine surgery. So though the Association of Spine Surgeons is a large group, but not large enough to spread this awareness among the public that the orthopedic surgeons do a fair bit of spine surgeries and in India, and that should be the mission. So as ASSI, we in the ASSI EC are very happy to help the IOA to spread this message across. And I hope the IOA executive team, Dr. Thakkar and Dr. Shiv Shankar and others join hands with us to take this forward. Thank you very much for inviting us, and thank you so much for spending this Sunday.
Thank you very much, sir. Mukhabaji, I want to say anything before we end up the meeting. You're muted, sir.
Before concluding, may I request Dr. Gautam Javhari to share his experience. I have heard from him 15 to 16 years ago, and I have 2 cases of using gel foam for controlled bleeding, but there are aseptic drainage for a few days. But I have seen one experience from that is a disaster. After a microdiscectomy, you put a gel foam, and you have to go to the operation theater at the midnight. So in this, that is a complication that is avoidable. And can you share, please, that for the junior surgery residents again once?
Thank you, Dr. Mukhopadhyay, for this question. I think this is a burning question whether to use gel foam. If you see neurosurgeons, once they do a craniotomy, they put in a huge gel foam into the brain and they are very happy. When they do multiple level cervical laminectomies for an intradural tumor, they use a gel foam over that, and somehow it doesn't seem to cause that much problem. They are happy using it. However, the current recommendations by the manufacturers of gel foam and such similar devices is that they should not be left inside the body. You can use it to control the bleeding and then, if possible, take it out. You are very right. There are 2 or 3 problems that can occur. The first problem is that when you use a piece of gel foam, after removing a disc and you put it there, the gel foam can swell up a little bit and become hard, and that can simulate a disc, and patient keeps on complaining of persistent leg pain post-operatively. So that is one option. Similar to your patient, I had a more difficult problem. I had a patient with a lumbar canal stenosis where I had done a 3-level decompression, and there was a fair amount of oozing intraoperatively, bleeding. And I used gel foam. This is years ago. This was about 17, 18 years ago. When I used gel foam, and I packed a lot of gel foam into the recesses up there in order to prevent this thing, the bleeding, and control it. And I did keep a drain also. But the patient was fine post-operatively, but within 48 hours started developing progressive neurologic deficit like a cauda equina syndrome. What actually happened, so I was forced to, I did an MRI. MRI showed a huge hematoma at the back, and therefore I was forced to re-explore. When I re-explored, what I found was that there were blood clots and the gel foam, they had mixed in order to form one big mass. And that was causing the cord compression. So we removed that, caused a little, washed it out and put in fresh drains and came out. She went on to recover well. So you are very right in being cautious about the use of gel foam. I routinely do not use any cover for after a laminectomy. If I've done a laminectomy or a hemilaminectomy for a dural decompression in a stenosis, I do not cover it up with a gel foam or a fat pad or anything. This has now been proven not to be useful. So the best method to do is to do adequate control of bleeding, hemostasis intraoperatively. Use a wide bore drain if there is a little bit of excessive bleeding, and let the drain remain. Don't be in a hurry to remove the drain. I generally remove the drain when the 24-hour drainage is less than 50 cc. I hope that answers your question.
Thank you.
So with that, I think we can conclude this morning session. Thank you all for sparing time and making it possible. Thank you very much.
Thank you.
Ashok, thank you very much for the links and you can close the meeting.
Thank you, Naresh. Thank you, everybody.
Ram sir, thank you very much. Yeah, we are leaving.